Hi, everyone, and welcome back to MedLink Global Runs. I am Ren Yang, CEO of MedLink Global. Today, we're doing something I've been really looking forward to. I'm joined by two remarkable leaders in psychiatry, Dr. Stefan Stahl, chairman of the Neuroscience Education Institute and professor at UC San Diego. It's great to meet you, Dr. Stahl.
Well, hello, good to meet you too.
Thanks. And Dr. Christoph Correll, professor of psychiatry at the Zucker School of Medicine and Charité in Berlin, and someone I'm lucky to work with at MedLink as a chief medical officer here. So today we're going to walk through 5 real-world patient cases. We ran each of these cases through Comentra, our clinical intelligence solution, and to see how the AI synthesize complex chart histories and suggest treatment pathways. Then we hand it back to Dr. Stahl and the Dr. Correll to see if they would what they would do if they're the treating psychiatrists for those complex cases. Before we unpack today's clinical cases, I want to give a few minutes to share to the audience what we built at MedLink. In everyday practice in psychiatry today in the US, the charts are huge and messy and fragmented, and clinicians do not have time to deeply listen to the patient and to listen to their whole story. So instead, they're expected to review hundreds of pages of unstructured EHR notes and track complex drug trials and spot hidden safety risks. All of these are usually happen today in the 15 to 20 minutes visit. That's why we're building this integrated clinical intelligence pipeline here from number one, the step one is the AI intake. Before the visits, patient will have a conversation like a phone call to share all the story of them, social history, psychiatric history, and why now, what brings them here today. The second is our proprietary psychopathology assessment co-built with Dr. Mark Blaze at Harvard Medicine that measures patient psychopathology severity and complexity. And last but not least is to synthesize everything together with years of EHR notes and history to give a treatment decision support. We call it Comentra as our treatment suggestion tool. And today's webinar will obviously focus on the step 3. Every case are already generated by Comentra for the treatment suggestion, and we will go through it. And about Comentra, rather than just a theoretical promise, we actually did a 12-month concordance study at a leading national health system. Christoph, you want to share a little bit more about the study? Please do.
Yes, so we wanted to put Comentra to the test, and what we did was a retrospective study in about 40,000 patients in this integrated health system. And what we did was we looked at what Comentra's output was and how much the clinicians in the past actually either did what Comentra recommended or did not do it. So that's like a concordance score that we got. And we followed patients from a decision point where something happened. They were just discharged, or the clinician made a medication change, or there were suicidal thoughts or whatever. And then we followed them 12 months forward. And what we found was that those clinicians that followed as closely as possible Comentra, their patients had significantly better outcome. They had better symptom reduction, better functioning, significantly so. They had less new onset suicidality, more remission of suicidality. They had less ER visits and hospitalizations. They had lower mortality rates, better functioning, and also lower cost, both in psychiatric and medical side. So that was pretty impressive. We're now repeating this because science lives on validation and repetition with another 40,000 patient cases in that same system, now not locking it at 12 months, but leaving it open because some outcomes like mortality might even kick in later. But that suggests that the Comentra, which is a AI-powered clinician decision support system, not replacing doctors, but giving clinicians an idea, what could this diagnosis be? What are the potential ranges of treatments that are evidence-based? This is not modeled based on cases, what happened to them. This is evidence-based care, which hopefully can also become somewhat measurement-based care, because as you might mentioned, our AI intake collects data. We also want the PHQ-9, the GAD-7, maybe even a clinical global impression in there to feed Comentra and have even more precise recommendations for doctors.
Well, thank you so much. So now let's dive in.
This is a 73-year-old male. So let me read this. Single, retired man living alone in wherever, admitted for inpatient psychiatric care and ECT evaluation with the chief complaint of I am depressed. So loneliness is certainly something that, and lack of support system can drive depression at that age. He has long been diagnosed with bipolar 2 disorder. Okay. He presents with a 5-month depression episode. The depressive episode worse since the holidays, now meeting criteria for severe major depressive episode with anxious distress. PHQ-9 is 21, GAD-7 19, so all in the high spectrum. His history includes a past manic episode with psychotic features, weeks of paranoia, quote unquote, which could speak for bipolar 1 disorder rather than bipolar 2. So that's the clinician trying to make sense of what's being told to him or her. Lithium plus amitriptyline worked well, plus amitriptyline, okay, from 1979 to 2017. That's a long period, until a hospitalization for lithium toxicity and acute kidney injury. Lamotrigine, olanzapine, and quetiapine were then trialed with limited benefit. A low-dose lithium restart 10 days before admission has brought minimal benefit. He had a prior successful course of ECT for depression and is motivated to pursue it again. Transcranial magnetic stimulation, TMS, is not an option given the aortic stent that he has. He reports suicidal ideation, wishes it could end. So that's more passive at the moment as far as we know, but we need more information. He had a teenage suicide attempt by overdose and is unwilling to confirm absence of firearm access. Ooh, okay. Good that he comes to the unit. Medical history includes chronic kidney disease, unfortunately related to lithium in this case, it seems, abdominal aortic aneurysm with a first-degree atrioventricular AV block and right bundle branch block, and type 2 diabetes with hyperlipidemia. He smokes daily, not a good idea when you have hyperlipidemia, diabetes, and a stent, but he does, and has a remote history of substance abuse with 3 inpatient chemical dependence treatments. So bipolar disorder and alcohol abuse. Now in early remission, early, not continuous, in the controlled inpatient setting. Oh, okay, so he may have drunk until he came in. He is socially isolated, retired, living alone, 1 daughter as a primary support. Social isolation is a risk factor for depressive relapse and suicide in bipolar illness. And he has good insight, high treatment motivation, stable housing, and healthcare access. So the diagnosis here is bipolar 1, currently severe depressive with anxious distress, rule out bipolar 2. He has tobacco use, unspecified substance use disorder, and early remission. Type 2 diabetes, hyperlipidemia, chronic kidney failure, abdominal aortic aneurysm, and hypothyroidism. Okay, so we want to know whether some of the depression has to do with his thyroid function, and that needs to be checked. Also, polyneuropathy, most likely from the diabetes, and urinary retention. Okay, I mean, amitriptyline worked in the past, but what is he on right now? Is he on any treatment?
Let's see here. Up to
So
present here,
basically,
these are the 2.
yeah, so it's on. Oh yeah, that was the trials that did. Okay, olanzapine 5, QAMN, maybe it's 5-BRD, no idea, and he's on lithium restart. Okay. All right. So Steve, let's go back to the case. Any thoughts about this complex case? Lots of medical stuff, lots of historical stuff, had already ECT, now coming back and needs help.
Well, I think it's bipolar 1, not 2. I think that he probably needs to be treated or both either for the up pole or prophylaxis against recurrence of the up pole, and treated for the down pole and recurrence of that. So in his current distress, I wonder whether amitriptyline is the best way to go. Lithium seems to be boxed out. If you're going to give olanzapine, you probably ought to give enough of it to work better. So 5 milligrams, it says, how much is the total dose? I can't see there.
QA and 7.5 in the evening, so it's 12 and it's 12. No, it's 10 altogether.
It's kind of a funny way to give it, but that's fine. You could even consider Lybalvi if you're going to give it to him at all, because of the the lipids and so forth.
So that's olanzapine samidorphan, who doesn't know the brand name exactly. Yeah.
Yeah. And so he probably needs some treatment for depression. And in fact, I was also considering olanzapine with fluoxetine combination if you're going to use olanzapine. But some of the other agents, the atypical so-called antipsychotics, could also be considered other than olanzapine, because he's got lipid problems, and to get him
and diabetes.
Yeah, so that's me. And this, I'm not sure that'd be my favorite way to treat this guy would be with olanzapine.
Okay, so bipolar depression, which agents would you potentially consider to replace olanzapine with? And let's see what Comentra then suggests.
Well, the problem with using lorazepam, which is one of my favorites, is that it doesn't necessarily work very well for mania. And nobody really wants to use very much valproic acid these days, although he's old enough to actually probably justify valproic acid if you really wanted to use it. Lithium is out. So I would prefer to have a better documented atypical antipsychotic for the manic phase. Something that works for both. I mean, even something like cariprazine, which is approved for both the manic phase and the depressed phase, could be considered.
Okay, let's see what Comentra suggests. Comentra goes with the ECT because the patient has been helped in the past. So this is the diagnosis, I think, clear. Yes. Also gives bipolar 1 as you do. It's not bipolar 2. Currently severe, and the rest are the longitudinal course is unclear. Okay, substance use is a concern. Obviously, firearm access is a concern because the patient is not willing to fully disclose this. Okay, now what happens today? What changes? ECT would be, he wants it, it has helped, but also discontinue amitriptyline, as you said, Steve. Cross-taper olanzapine to cariprazine or lumateperone maintenance. So cariprazine has approval for both mania and bipolar depression. Lumateperone does not yet have indication for mania, but is an antipsychotic for schizophrenia and has very powerful effects on depression with very little side effects. Maybe together with lorazepam, the least cardiometabolically toxic or problematic. So in that sense, it may even be a better choice than cariprazine for this person with diabetes and dyslipidemia. Okay, discontinue amitriptyline because anticholinergic burden, as you also may, and mania induction. Lumateperone may have the advantage that it also has an SSRI built in the molecule, as well as maybe D1 related ampakine increase. So in that sense, it may be a very powerful antidepressant. The course of bipolar disorder is unclear, but he seems to suffer the most from the depressive episode because in the history, it's not even clear bipolar 1 or 2, so maybe he had one manic episode. So we need a good antidepressant that doesn't kick people into mania or has the shield. And then exactly switch cross-taper olanzapine we already talked about. All right, psychotherapy also in order to get him reintegrated with social contact, supportive psychotherapy on the inpatient, and then after discharge, transition to CBT and interpersonal social rhythms therapy so that he gets more into interpersonal rhythms again and hopefully has some beneficial effect also on his substance use. All right. Seems to be not a bad plan. What do you think?
Yeah, I mean, I don't think it really matters what kind of psychotherapy he has. This guy probably just needs regular contact to keep him on track.
Yes. Sometimes the psychotherapist is the only regular contact these people get, but maybe with that help, he can open up to have experiences with people that may not only be seen as potentially negative and dangerous. That's where the CBT comes in. He may have locked in himself, locked in into this negative
What about the
worldview.
diagnosis of lonely? That's a popular one today. I mean,
Yes.
I'm not really being funny here, but I mean, quite frankly, an older guy that has these medical problems and isn't working and lives alone, he could be lonely, and that's maybe different than depression.
Yes, absolutely. Okay, what were questions? Just to see what Comentra would have wanted to know if there's anything. All right, when did your first mood episode start? Was it depressive or hypomanic? So basically, that's the mood polarity. What do we need to treat most, depression or mania? I had inferred that it's mostly depression. Can you describe typical frequencies, severity of past and current depression and hypomania? What specific stressors, life events, medication changes typically precede a mood disorder, and that might be loneliness. For past medication like lamotrigine, Seroquel, which is quetiapine, what specific side effects did you experience? Why were they stopped? So to know, do I want to avoid a certain side effect with the drug to not get into this trouble again? Have you ever been engaged in specific psychotherapies? And was it helpful or not? And when did you have ECT? How many treatments? How long did it benefit you afterwards? So that's an important consideration. Also, if we want to give ECT now, what was the ECT history? All right, I think would help us to even sharpen the plan further. Move on.
Yep.
All right.
This is our last case.
All right. So Noah, let me read this again. This is a 16-year-old. All right. So almost an adult. A 16-year-old male referred from inpatient neurology for urgent psychiatric consultation for progressive encephalopathy with prominent catatonic features. Over the 3 to 4 weeks before admission, his family noted rapid onset behavioral withdrawal, confusion, psychomotor slowing, intermittent mutism, stereotyped posturing, and staring episodes. He has no prior psychiatric diagnoses or treatment and was a high-functioning, socially engaged 10th grader. Neurology first evaluated him for altered mental status and seizure-like episodes. Psychiatry was consulted to characterize the catatonia and guide acute management. Neurology started empirical lorazepam. On evaluation, he's hypokinetic with markedly diminished speech, intermittent posturing, and waxy flexibility. Cannot give a coherent history. He voices no suicidal or homicidal ideation. Safety concerns stem from his disorganized, confused state, impaired protective reflexes, and unreliable self-care. Etiology is under investigation: autoimmune encephalitis, infectious encephalitis, or metabolic causes. So it seems they have ruled out drug intoxication, which obviously in a 16-year-old in college would also be a consideration, but that obviously is tested when they come to the ER right away. All right. Any thoughts here?
This is scary. This a kid like this looks like there's something wrong with his brain. This does not look like the onset of first episode of schizophrenia. Very would not be that kind of a presentation. There's something wrong with this guy's brain until proven otherwise. And I think the chances are it's, for old-fashioned term, organic. And I think we just have to search for that, whether it's like you say. I'm sure he's had a lumbar puncture. I'm sure he's had a brain scan and so forth. He's had metabolic workup to try to find out what it is. But I think encephalitis is a high possibility here. It's taking the form of catatonia, and while you're investigating it, I would like to know what the dose of lorazepam is, because particularly neurologists, but even some inexperienced psychiatrists are afraid of dosing lorazepam high enough to work in this situation. So you give a 0.5 milligram or 1 milligram, or maybe 2 milligrams, and then it doesn't work, and then you stop. Sorry, you may have to give quite a bit more.
Yes, so at Hillside Hospital, we have like an upper cap of 16 milligrams. After that, per day, you need to get further approval. And there's also this IV test that you give every minute, another milligram, and see whether people wake up or fall asleep to differentiate this. But let's see what the health timeline and diagnostic assessments are. So basically, we don't have much more. Do you have a Gantt or table view?
No, I think this is a table
Okay,
view.
it all was acute, so we don't have a past history. So we now have lorazepam initiated empirically. Well, let's see what the dose is in a minute. Also, he has some lever.
Yeah, the dose seems like very unknown.
Maybe because of it's an anti-epileptic. Okay, and then neuropsychiatric case. Okay, diagnostic assessment. So until proven otherwise, a medical condition, as you say, it's a catatonia due to another medical condition, unspecified encephalopathy, catatonia. We have that acute etiology under investigation, and it's there could be depression that people missed, but why would it be that acute? But it's certainly something to bear in mind. Catatonia is more often associated with depression than even schizophrenia. Urine substance use test, yes, of course. Intoxication as a trigger. I had expected this, but yes, it's something that needs to happen. And then whether there's an NMDA receptor autoantibody, encephalitis, or another autoimmune condition. So as you said, spinal tap is important. What about a brain scan? Okay, and then let's see what the treatment strategy is. Okay, here's the escalation lorazepam. Basically 2 milligrams IV or IM, repeat every up to 8 or 12 milligrams is tolerated. Is here we again have up to 16, but that's reasonable. Establish whether an ECT consultation pathway at least. So if lorazepam doesn't work, the patient gets even worse. You want to have at least a trigger that if there is ECT in the house, something that works even better than lorazepam. We want to optimize it every 6 to 8 hours, 1 or 2 milligrams. I mean, I know that it's given, yeah. So 1 to 2, then you would have it either 3 times or 4 times. That could be up to 8 already. Titrate every 24 hours on response. Look at speech initiation, oral intake, and also whether there's oversedations or respiratory depression. Obviously, there needs to be vital signs every hour. They need to see whether there's hypertension, a pulse elevation that could become malignant catatonia. What about febrile or even very stiff febrile episodes or very stiff muscles, because that could then translate into myoglobin breakdown and the acute renal failure. So we need to make sure the patient is also hydrated as much as possible. Okay, and then medical admission is mandatory. Absolutely, as you said, it's scary. Supportive care, vital sign. Oh, there it is. Hydration, nutrition, if needed, and deep vein DVD from prophylaxis because he's not moving much. He's mute and stuporous almost, and we need expedited etiologic workup, lumbar puncture, EEG monitoring also, and also CK to see whether there is this strong catatonia, which could even become an NMS-like or malignant catatonia case. So seems to be pretty comprehensive what Comentra wants us to do. Counsel and educate the distressed family. Yes, he's 16. Supportive psychotherapy whenever he can engage in that. Any questions for the patient? Most likely not, but are there questions to the family? Let's see, questions to explore. Was there a prodromal phase of psychiatric symptoms? So just to make sure we're not missing schizophrenia, anxiety, psychosis, sleep disturbance in days or weeks before the neurological symptoms became present, despite patient and family denial of substance access. A comprehensive objective drug screen is obviously needed, also for things that may be missed on a urine tox. especially with some of these more synthetic kind of drugs that are currently being put together in some basements or garages. MRI brain findings, what are different signals and medial lobe, basal ganglia or cortex, and then EEG, is there any extreme delta brush pattern with anti-NMDA receptor encephalitis. All right, so we need to work closely with neurology. We need to have also our psychiatry experts on ECT on board, liaise with neurology, make sure that benzos are not underdosed and that this doesn't escalate into acute renal failure and that he doesn't become stuporous and maybe then get aspiration pneumonia or something. So he needs really consultation liaison services and further workup. Yeah. Steve, anything else?
Well, I'd like to see how this turned out. I'm going to ask you this. I don't know that I've actually seen a case of NMDA encephalopathy myself. Have you?
I've seen it now, and because of the CNL service that we have in the hospital. Yes. So these are acute onset patients that are psychotic, but also quite disorganized, don't have orientation to a place or person. And when you then treat them with plasmapheresis or other treatments, they can really clean up quite a bit. But it looks different than schizophrenia because it's so acute, and there's also some problem with orientation and sometimes also with vigilance.
Yep.
So, I mean, it has the differential of either depression or psychosis with catatonia, makes sense, but our first provisional diagnosis that this is medical, but needs to be co-treated with the psychiatrist.
Yeah, in the absence of horrible sort of organic lack of consciousness and or orientation, whenever I've seen cases like this, they've really turned out to be horrific onset of a psychotic illness. I've not actually seen a case of NMDA, or at least I maybe have missed it, but I haven't seen one that was diagnosed. In fact, I'm wondering, since I've been around the block maybe a few more years, I wonder whether in the old days I've missed some, because we never put this in the differential diagnosis, 30, 40 years ago.
Of course,
so,
yeah.
So we didn't think of
that we
it.
recognize
So
this.
it's possible that there were some of those cases back then, but I have seen cases that look very, very sick. They look like there's really something organic going on with the brain, and it just turns out to be bad psychosis. And they can remarkably, I mean, you can actually transform these people in one ECT session. It's just absolutely remarkable. And also, when you sort of give 12 or 16 milligrams of lorazepam, when you think you're going to put them into a coma, they wake up and start talking to you. They start dressing, they shave, and they eat breakfast. So it's actually pretty amazing. And one of the things that we've forgotten in psychiatry is the differential diagnosis of catatonia. So it's a good case.
Yes, absolutely. And there's been some research into what underlies catatonia when it's a psychiatric symptom. Georg Nordhoff, who's also a philosopher and a medical doctor who's now in Ottawa, has done research on it. And he's done a couple of interesting experiments. So first of all, patients are stuporous, and that's voluntary movement, because when he threw a ball at them, reflectively, they actually caught it. And then when they came out of catatonia, he asked them, what was the experience like? And there are three types. The middle type is a mixture of the two. One is extreme fear. It's like they're freezing because they think if I make one more step, the world will come to an end. My mother will be killed. And so they're basically frozen in this extreme fear. And on the other hand, it's passivity. I can't move because somebody is making me assume this position. So it's either extreme control by some force, that's the psychosis, or the extreme fear out of paranoia. And then there's the mixed case where they have both. So I felt this was quite interesting. What was the mental representation or origin of this motor severe manifestation. Quite interesting. But we see less catatonia than is described by our elders. And so maybe that has to do with earlier use of antipsychotics, better treatment, whereas maybe some of the catatonia where patients were just standing for weeks and months in an asylum were due to untreated dopamine dysregulation. So very, very interesting. And it has also to do with the fact that, like negative symptoms, we have too little dopamine, psychosis in the associated striatum, we have too much dopamine. But then what about the motor strip, where we have basically both potential spontaneous dyskinesia, where it's too much, or the catatonia, where it's too little movement? So it's really an on-off excitation inhibition dysregulation syndrome, what we see in psychosis and schizophrenia. Which
some people think it's mental. Some people think is a model of the world's worst case of an EPS. It's basically frozen. It might be striatal, essentially. It's something that's a form of Parkinsonism that's frozen. I don't know if that's right, but there are people that conceptualize it that way as well.
Yes, but there's also the waxy flexibility and the Gegenhalten and Midgain, where it's passivity phenomena. It's quite complex. But anyway, hopefully this guy, we don't have follow-up here, woke up out of all of this, which if it's that acute, often it can then also be acutely treated. But at least Mantra, I think, did a good job here, helping the patient and the team to think of the benzo and high dose benzo, not like you said, sprinkling something, and also having ECT already on the side, even though you're still doing some of the assessments. Okay. Also, the questions were good to differentiate. As you said, it could be still psychosis. That's really a very horrific form of it. So keeping all of this online while evaluating the patient and having Comentra giving some suggestions can be helpful. I mean, it can still be refined, and we're in the midst of doing so, but it certainly gives one a broader horizon upon which to base one's evaluations and next steps on. All right. Any final words from you, Steve, over this exercise?
No, it's a good case discussion, and yeah, it makes you think.
Yes. Thank you for thinking with us and giving us your thoughts. Very, very helpful.